So just to say thank you to Dr. Vince for coming to talk to us about START. I know some of us have already done it, and there's probably others who are keen to learn more. And Dr. Vince, I believe, is on the START's panel from the RCPCH, and is, correct me if I'm wrong, an intensivist down in London. Is that right? But your previous sessions have been very useful. I know helped me get my head around getting ready for START. So I'll hand over to you, and we'll keep a lookout for any questions in the chat for you as well.
No worries. Thank you so much. And thank you for inviting me back. It means that the talk can't have been that bad. So for everybody else here, so yes, I'm a pediatric intensivist, so I don't do babies unless they've gone home and come back in. But I'm vice chair of START as well, and I'm actually responsible for the assessor training. But obviously, once you get involved in something, they bring you into lots of other things. So, you know, I do lots of writing of scenarios, etc., etc. Could I have, by a show of reactions, how many people have, number one, already done this, as in have already done START? Okay, so I'm speaking to the converted, which is great. And actually then your contribution to this will be really helpful to other people. If everybody else kind of takes a look at names, and then, you know, if you have any other questions, you can go to them. I think START has a lot of myth around it. I think before you do it, I think it's quite scary because it costs you a lot of money, and you kind of think, oh my God, if I don't pass START, then I won't become a consultant. So I'm here to bust those myths. And I think much like the membership and finals and every other exam you've ever done, once you've done it, you go, was that it? And it all seemed like a much nicer affair. And hopefully after this talk, you will feel better about START than you did before this talk. Presumably all the people who, or most of the people who've done it before, have heard this talk before, but has anybody else heard the talk before? I'll try and put in other jokes then. Okay, cool, excellent start. So then I can use all the jokes from before. Right, so you can see my slides. This is what START is, and although it says June 2022, I actually updated it this morning. So this is for you guys, all right? By the end of the session, and I will do this as a whistle-stop tour, it will be recorded because I actually think it's much more useful for you guys to be able to ask questions, yeah? By the end of the session, you will understand why we do START. You will understand it is not an exam. This is actually an assessment because it's completely formative. And if we've got some time, we'll have some practice scenarios that we can have a look at. So why do we do this? We do this basically because the GMC want us to do it. And we kind of understand that actually there's a big difference between training and not training. All these other institutions, though, they do proper kind of knowledge exams, like the third part of their membership. And I think that's bonkers because by the time you reach the hallowed heights of ST7 and ST8, you should know all of this stuff, and making you revise for an exam, I think, is really heartbreaking. So we don't do this in pediatrics. We're way more sensible. What we do is actually we recognize the things that you do are clinical. I'm sure all of you can get a PhD in asking for a chest x-ray and writing discharge summaries, but the bits you don't get to do are the non-technical stuff, the non-clinical stuff almost. So that's what we call non-technical skills, and that's what START hopes to assess. This is done according to the GMC, who says, actually, rather than talking about kind of objectives, SMART and otherwise. They now start talking about general professional capabilities. And you'll see on the right-hand side of the screen how this all comes together. And you should be familiar with this because this is the backbone of Progress Plus. And this is what is coming across in all colleges. And in fact, PEDS was the first one to be approved by the GMC. How does this translate to START? Well, what we do in START is we have 10 scenarios, and you can see, for example, if I'm talking about research and scholarship, that will be assessed in the critical appraisal scenario, etc., etc. So what I'm going to do at this point is go through each scenario type. Critical appraisal is where you will be sent a paper. You'll be sent it about 5 working days before your assessment. And yeah, sure, you can chat about it with other people, but what we want to see in the scenario is that you are able to review a paper in relation to your population, and we'll give you a bit of a scenario on the day. And so how you translate that across to the needs of your scenario. Yeah, it's not very difficult. There are lots of papers and publications and podcasts and webinars on how to critically appraise a paper. The paper is likely to be general pediatrics because that suits everybody. The next one is safe prescribing. Safe prescribing will come into patient safety and quality improvement. And that generally is that on the day, you get a bit of prep time and we will give you a drug chart. You have to find out what's wrong with the drug chart. And it's as if somebody has made a mistake on the drug chart, or they've prescribed the wrong thing and it's an unsafe thing, like they've prescribed 3 grams of arsenic 4 times a day, that kind of thing. You have to find out what's wrong with the drug chart, and then you have to talk about why it's wrong. So it could be subtle because you're at consultant level, not membership level, and what you're going to do about it. So therefore, that is a bit of patient safety. It is a bit of education and training for the people involved. It is a bit of critical incident management as per a DATIX. Next is teaching. We all teach all the time. What you will have in this is we will give you a short list of topics, and you can pick any part of that. So for example, if we say we want you to teach on bronchiolitis, you could teach about the management of bronchiolitis, the pathophysiology, how common it is, anything you like about bronchiolitis. The important thing, though, is you pitch it to the people. You will have people in the scenario who are either real for life medical students or real for life STs 1 and 2. So clearly, teaching a medical student is subtly different to teaching an ST 1 or 2. So you need to be able to pitch to that team. So please don't come talking about your PhD work on RSV. Pitch it to the people in front of you. We're not so worried about the content. We are more concerned in how you go about teaching. So do you pitch to the people in front of you? Do you cover adequate stuff and not too much? Do you check in that people are understanding you? Do you make it interactive? No slides, please. You won't have time. Use pictures and stuff on a bit of paper that you hold up to the screen or whatever, but only if it assists you by augmenting your teaching practice. Yeah. And of course, it's only 8 minutes. How much do you honestly think that you can cover in 8 minutes? For those of you who have done a GIC course for resus, this is a bit like teaching from that. So don't expect to cover everything, but cover a small portion of a particular topic. Conflict management is, as it says on the tin, really. How do you go about managing conflict? Now, the conflict can be anywhere, any shape or form. So is it with other teams, other specialties? Is it with a junior? Is it with management? Is it with parents? Whoever you like. And the interesting thing about conflict management clearly will be not just your perspective, but it's going to be, how do you get a win-win for everybody? And my overriding theme of START is make sure you cover everybody. So here, the conflict management will be you, it will be the other party, but it will also, you've got to have a nod to the GMC if required. You've got to have a nod to your institution or organization if required. Okay. There is nothing that can't be made worse by the lack of an apology. Even if you don't mean it, you got to say it. Okay. And it's not, I'm sorry you feel that way, because that's very passive aggressive. We don't say things, nonsense like that. That's gone. Okay. And if those of you who really need to see, I'm sorry you feel that way in action, watch Succession. They didn't mean a single word of their apology in that series, but they said sorry multiple times. Okay. So we are not Elon Musk or any other horrible person in the world. We actually are sorry for the distress that the situation has caused. And even if you say something like, I'm sorry you're having to go through this, people will turn around and say, well, it's not your fault. And you quite happily turn around saying, I'm trying to be empathic rather than admitting liability. Something like that. Make your apology genuine. It aligns to your values. I know it does, because we've all come into a really hard part of medicine, because no one chooses in their 50s and 60s to be on call at 3 o'clock in the morning. So we have not chosen the easy path. So therefore, we really want to help people. So align with your values in terms of conflict management. Handover. Now, if you are, so basically in handover, we are assessing your prioritization skills. You will be given a handover sheet, and your job is to prioritize which patients need seeing and by whom in your team. And we will give you who you have in your team. This will either be a general pediatric handover, or if you are a neonatal grid trainee, not a neonatal spin, but a neonatal grid, you will get a neonatal handover. Okay. But everybody else gets a general pediatric. Now, lots of people whinge at us because they say, well, I'm an oncology spin or I'm an oncology grid trainee. The last time I looked after bronchiolitis was 2 years ago. Yeah, that ain't going to work, because you still come out of it as a pediatrician, according to the GMC. So, and it isn't rocket science. You know, if you've got someone who has got SATs of 88%, you need to see them sooner rather than later. Yeah. If you've got someone who's got a safeguarding issue, work out who in your team is best placed to look after them, etc., etc. Okay. The content is not esoteric. Yeah. Ethics. Ethics obviously is a big part of our job as a pediatrician. And again, the principle of make sure you look after everyone comes into play. So, for example, if we said, oh, you're going to go and see a family who are considering a termination of pregnancy for gender reasons, how will you handle this ethical situation? Well, you've got to look at your ethics, how it affects you. You've got to look at the family's ethics. You've got to look at the child's ethics with a nod to the GMC, because we all belong to the GMC. Okay, so whoever is involved in the scenario, make sure you address their needs at some point. Safeguarding is common sense. How would you manage a safeguarding case? And of course, the safeguarding cases could be all sorts of things, as long as it does involve harm in some way to some member of a family. What you'll then have is 3 case-based discussions that are rooted in your specialty. Again, if you are a neonatal grid trainee, it'll be neonates, but it isn't going to be about content. How do you manage a premature baby of, 27 weeks gestation? It's more like, how do you manage the ethics of looking after a 22-weeker? How do you manage conflict in a trainee who's just not doing what you expect of them in the neonatal ICU? How do you manage your colleague who refused to intubate a baby and the baby deteriorated and died? So those kind of principles, it's still general professional capabilities. It is not knowledge. START does not replace your other assessments, it adds to it. When you come through to being a senior trainee, ST7, and for some of you ST8, you still have to do your workplace-based assessments or your SLEs. You still have to have your portfolio. But what START provides is a really strong indicator of the non-technical skills you need to have as a day one consultant. So it feeds in to your assessment strategy and really hones down your final or penultimate ARCP. Because what you will get after START is feedback. The feedback will tell you where you are now, i.e. at the time of the assessment, where you need to be. So where you need to be is written down is what was the scenario looking for. And each scenario will produce a template feedback, which starts with the scenario was looking for. So that kind of tells you if you went way off piste or if you were quite close to hitting the target. Where you are now is the personal feedback that you get. You were able today to discuss some of this. I would have liked to have seen more. Remembering you are a year or 18 months before you become a consultant. So if you need further development, we are saying you are acting where you are now, i.e. a senior trainee. What we are assessing is, are you meeting the standard of a day one consultant? So actually, you shouldn't expect to be at a day one consultant because you're 12 to 18 months before it. And I think this is really important for those of us who are neurodivergent, because how can you picture yourself doing something that you haven't experienced? That can be very difficult for people. And actually, they find the feedback really unfair because I've been shown to have further development. I don't take it like that. I actually think if we didn't tell you 12 to 18 months beforehand where you needed to be, you have absolutely no opportunity to act on that feedback. So this tells you really clearly, hopefully, this is what you need to work on. So that day one consultant is not as scary, okay? Some of you, however, will have had enough experience and exposure during your time, maybe because you've taken some time out, maybe because actually you've come from a different specialty, etc., etc. And you may be functioning at a 6-month consultant level, which is the exceeds expectations. And you will know this because we'll tell you what the scenario is looking for and we'll tell you how you did. The final bit of your feedback will be, what do you need to do to go from here to here? And that is pragmatic, tangible steps that come into your PDP. When your ARCP panel look at your ARCP, they are very rarely interested in what you got in your START, as in how many exceeds, how many meets, how many needs further development. What they will look at, again, is not what you've done, what you have learned from it, and that is your PDP. So your PDP is absolutely crucial, and I would advise you very strongly to get your ES to go through your PDP with you. They will be able to make it very, very tangible. Now, clearly, you're going to have 10 lots of feedback, And that may mean 30 practical, tangible steps. You don't have to do all 30. Clearly, that would be not feasible. So you have to pick the ones that are going to give you most bang for your buck. So very simply put, RCPCH START is not an exit exam. In all my years of doing START, no trainee has failed to get their CCT on the back of START. What START does is an external independent review that seems to somehow confirm what your educational team think about you. So if there are concerns about your communication style or you know, how you work with other people, this somehow seems to pick that up, and therefore we can send that to you and your ES, and then, you know, well, actually, I really do need to think about this. It really isn't like this. It is 10 SLEs in a row, that 10 case-based discussions in a row, and you've all done at least 10 case-based discussions, so you've already done your START assessment effectively. At that point, I'm just going to pause. Are there any questions anyone wants to raise verbally or in the chat?
Nothing coming up in the chat as yet.
Ace bananas. All right, well, I'll carry on, okay? So, START is multi-scenario, multi-sit. Sorry, you must sit it. You cannot get your CCT by not sitting START. But given what we've learned in the pandemic, the START board do lots and lots to put on extra dates for people whose CCT is very, very close. When you apply for START, and you should be applying for it a good year or 18 months before your CCT date, we will prioritize those whose date is sooner rather than later. It is formative. The key for this assessment is feedback to you, and it is for all pediatric trainees. So you really can't avoid it. And although it's scary shining a light on yourself, I haven't found anyone who has regretted taking START. I think that people have gone, I knew I needed that. Now START has said I needed it, and therefore my training organization must give me that opportunity. Or, I didn't realize. Now I need to go and find those things out. So, like I say, everybody comes out of START going, not a maniacal grin, thank God it's over, but, I learned a bit about myself today as a trainee. The general logistics of how we run START is that we run it 3 times in a particular month, and you only attend for half of those days. So we're looking to go through a fair big batch every time we run the assessment. And at the moment, we're probably looking at 3 times a year, if we can get the trainees, if we can get the assessors. We do 2 to 3 circuits at the same time, and we make sure that the benchmarking criteria, i.e. what the scenario was looking for, is standardized across everyone. So whichever scenario you get on whichever circuit, you know that your counterparts on other circuits are seeing exactly the same and being assessed at a similar level. We run 2 sessions a day, AM and PM. So this is really useful for those of you who have reasonable adjustments. If you don't ask, you definitely won't get. But in terms of reasonable adjustments, if you have specific learning difficulties such as dyslexia, you can ask for extra time and you get extra reading time. Okay, if you don't ask, you don't get. Okay, if you have issues with mental health, such as neurodivergence, anxiety, depression, anything like that, and you find assessments, SLEs, examinations stressful, if you can provide objective independent evidence of this that says, I would prefer an afternoon rather than a morning, then actually go for it. It's not a problem, okay? And you can ask. If you don't ask, the answer's no. Doesn't guarantee that you'll get them, because actually what we find is the people who don't get reasonable adjustments are those people who have no evidence for it. Some of the things are covered by anticipatory assessments, so adjustments. So everybody gets them. For example, everybody gets a break in the middle of the circuit, right? And that is for people who just need a moment to gather themselves and center themselves. But it's also for your assessors to catch up with any feedback that they want to give you. Because remember, they don't get breaks in the circuit. You will get a break because you're doing prep. They therefore have a consistent cognitive load, and that needs to be managed. Okay? So you as a trainee will do 10 scenarios in half a day, but you know, lots of other trainees will do scenarios on other days. And those scenarios may well change because actually these, even if you have known what the scenario is from somebody else, it's how you perform on the day that's really important, and knowing the content doesn't actually help you. Yeah. And obviously if it's easy for us to change it, we will. So for teaching, for example, you know, one day might be airway issues, another day might be breathing issues, another day might be cardiovascular issues. But cardiovascular issues might be, how do you manage gastroenteritis and oral rehydration therapy? Or how do you manage hemorrhagic shock? You know, that kind of thing. So the content, if it's easy for us to change, will definitely change. And if we don't change it, the principles that you discuss are the ones that you choose to discuss, not anything else. Okay. And I'll talk you through how to revise for START. Here it is, as if I planned it. The main revision for START is come to work. You will not do this if you don't come to work. Okay, so some people who do this on their maternity leave, well, they haven't left work for ages, if you see what I mean. They are still there, they're still managing it. I don't like people doing it on maternity leave or any other sick leave because you're not at work. You're off because you have other more pressing needs. But if you really want to do it when you're on mat leave, go for it. If you are on any other type of leave, like sick leave, compassionate leave, please, for goodness sake, okay, your health, your well-being, your welfare, way more important than START, and we can always organise something else for you. I think you really, I mean, you probably do, and I'm probably old enough to be everybody's mother. You probably look after yourself better than I do. But I really want you to know that as consultants, we want to look after you too. So we might get a bit maternal about the whole thing and say, you ain't doing it. You've just had an operation. Don't be so silly now. Obviously in much more polite terms and less condescending terms. But the point is, come on now. We really need to look after you. The other way you revise for this is talking to people. Don't act in isolation. Take the opportunity to say, well, can I run this past you? What would have happened if? Use your colleagues for informal CBDs, informal SLEs. Yeah. How would you have managed that situation or that kind of thing? Yeah. These are 10 SLEs. Hold on to that. My other piece of advice is read the scenario. I've already really laboured the point, consider every person mentioned. And the ethos of START is not solve everybody's problem, because you can't. But how do you manage, and what is your approach to the scenario? You can't manage everything alone. Remember, there are other people you can go to, not just your colleagues who are around, because sometimes they are, sometimes they aren't. But actually, sometimes you need to raise concerns. For example, you might need to go to the college tutor for a trainee. You might need to go to the postgraduate medical dean. You might need to find out who the ES is in their next post, for example, and then contact them. With longitudinal training, clearly that's longitudinal supervision, that's easier, but you still might need to know who the clinical supervisor is going to be at the next post. And you can, you know, share information appropriately with them. So those are the main scenarios. How do you go about preparing for them? So critical appraisal, go read a paper on how to appraise a paper. Safe prescribing, just make sure your prescriptions are safe and think about how you would manage a mistake in a prescription. I cannot believe that no one has ever made a mistake in prescribing, so you can dig back into your own memory bank for that. Teaching, take every opportunity to teach. If you work in a teaching hospital, you'll have medical students, become part of their teaching rota. You've got junior trainees that you can teach. You've got nursing people that you can teach. You've got allied health professionals that you can teach. Take every opportunity to teach. Okay? Conflict management. I think there are things that you can do. So nice guidance will help you in your scenario-based things and in the critical appraisal one. Confidentiality, you need to have an understanding of the GMC guidance on confidentiality, consent, and capacity. It's common sense, really. I don't think you need to know chapter and verse. I really don't think you need to know paragraphs. You do not need to know how to quote them. You are not a lawyer. But the general principles of confidentiality, consent, and capacity should be understood, as should the duty of candor. Just read it up. Your trust will have a policy on it. A colleague in difficulty, whether they're a peer or a junior, using, for example, the examples that I gave you earlier on. Answering complaints. I bet you none of you have answered a complaint, but going about that, again, the general principle of human factor management, human error management, and unhappy people management. Managing datixes or in phases, or either way, serious untoward incidences, is all about conflict management as well. Safeguarding is safeguarding. If you haven't done it for a while, quickly do the e-learning modules on safeguarding level 3, which you will find on e-learning for health. That will just bring it back into your working memory. So for you, don't watch other trainees too much. Don't take too much advice from other trainees because they might have a different schedule. Because we run this as a virtual assessment, there is no formal dress code. I would say, though, that I think you should dress as you would for work, because that puts you in the mindset of being in work zone. Some people can immerse themselves in an assessment and do it in their pajamas. I don't mind, really. But if you come looking as if you've only just woken up, it doesn't set the tone and it doesn't fit with you. Equally, I think that if your assessors look like they've just got out of bed, you will have an impression of them as well. I don't make my assessors wear work clothes. You know, you'll see them in tracksuits or jeans or something like that. I've had some assessors do it from their garden, which I think is delightful. I've seen trainees do it with their cat on their shoulder. I have seen them do it, you know, subtly handing off a baby that they've just finished breastfeeding. Whatever it takes to make you feel comfortable, I don't give a monkeys. I want to see the best of you. From an assessor point of view, the assessors don't really like the virtual environment because of the issues that can arise. Trainees absolutely love the virtual environment because they don't have to travel. They can be a bit more relaxed. They can have a big mug of tea and a baby breastfeeding and a cat to stroke, etc., etc. I wouldn't have your dog in your room because dogs tend to bark. Okay, cats just meow a little bit and they're fine. Okay, they're all right. So yeah, the other thing to suggest, though, I don't necessarily think you should be doing it in your garden because you're the one that's going to be doing most of the talking. Okay. And you don't really want other people to overhear you. You've got a secret audience from other people in the garden and stuff like that, or other neighbours around. And, undoubtedly, wherever you live, somebody's doing some flipping renovation on their house. And so you get drills and you get plumbers swearing at each other all in the background. It's too much of a distraction. My advice, though, is when you get sent your OSLA logins, test your system. Test your system with everybody in the house using every piece of bandwidth of your Wi-Fi. That way you know whether you might get into trouble. On the actual day, however, get rid of everybody from your house. No kids watching Bluey in another room. No spouses playing Call of Duty on the Xbox. No nannies watching TikTok. Get rid of everybody in the house so that you maximize the bandwidth for you. Do not do it from work. And we tell assessors this as well, because your trust firewall may stop you from accessing the platform. And the last thing you want is trouble with platforms. I have probably cancelled START for more trainees with Wi-Fi issues than I have had to, stop them for any other reason. Okay, it happens at least once a diet and it doesn't need to happen. Yeah, do everything you can to prep that you can do your assessment. We will give you a briefing before you start that will let you know about when your results are due. What are we looking for? We are looking to see where you are now, the good trainee, which is actually where you are, day one consultant, 6-month consultant. There is something called significant concerns, which is, it sounds quite scary, and I think it's alarming appropriately. A significant concern may be this overall scenario was a significant concern, or it could be that one aspect of it was a significant concern. What significant concern implies or denotes is that we feel that this is so important, you must deal with it in your PDP and you must take advice from your ES on it. If you're a good trainee, it's called needs further development. And those are the things that are nice to sort out in your PDP, but they're not mandatory. Okay. And what we will try and do is to explain to you what you need to do to be ready to be a consultant. So how do you go about creating your PDP? Well, firstly, do you have any significant concerns? Significant concerns happen about, I would probably say 1 to 2 per diet. So that's 6 trainees a year. And you can get significant concerns in up to 10 scenarios. Now, clearly, if you had significant concerns in 10 scenarios, that would be a concern and your ES would know about it. Currently, what we're doing is we are notifying your ES if you have more than 2 significant concern scenarios. Because that means you can't hide from this. That means you don't delay managing this. It means we need to get on and sort this out. So if you have significant concerns, it must be addressed before you can receive your CCT. So this is decided by your ARCP. It's a really good idea to link it to GPCs and also to Progress Plus. However, the vast majority of you will get some needs further development. Have a look at the feedback. Are there themes across your scenario? So for example, I've seen one where a trainee got about 2 or 3 needs further development, and it was all about the organization of their discussion. It didn't make smooth progress. It jumped about a bit, and therefore the information was lost. Well, if you deal with that, that's perfect training for a consultant interview. It's also really important clinically that your explanations to patients and to other teams is not lost because of your communication style. So if there are themes, the theme would be, I need to look at this, and I may want to go on a communication course. I may wish to undertake some e-learning on communication. I may wish to get more feedback on my communication. And clearly, you need to prioritize those scenarios where either the overall assessment was NFD, or in the individual scores, you've got more than one NFD. For all the other scenarios, have a look at what your themes are, and have a really high threshold to say, oh, it was nerves. Because if it's nerves, you will start badly and you will get better. But if it's coming through again and again, that doesn't really wash. And also, I think to say it's nerves means you lose the opportunity to manage a hot situation at work, which will inevitably be racked with nerves. So don't go down that route of, oh, I was just nervous, even if we say you appeared nervous, yeah, because we're just one scenario and one encounter. As I said before, pick 2 to 3 goals maximum, and that makes it achievable on your PDP. And here our suggestions are merely that. They are suggestions. They are not mandatory. The mandatory ones are only the significant concerns. And that are my slides. There is no more. So I'm going to stop sharing now. And I'm going to put my camera on so I'm not just a voice in the distance. Hello, good morning, everyone. So we've got 9 minutes left. Are there any questions? I'm not going to come back at the end of the day. So now's the time to plunder me with questions.
I'll keep a lookout on the chat. I had a quick question that I don't know if this is a West Midlands specific thing, but there's sometimes a talk about putting something on your portfolio as a START reflection in addition to the sort of PDPs. And I don't know if you had come across that or any particular advice.
Yeah, we have. It's not mandated by college. It's not mandated by START. As an educationalist, do I think it's a good idea? I think it's a brilliant idea because you will get your results and your feedback some 6 to 8 weeks down the line. But if, for example, either the same day as your START assessment or the day after, you wrote down a reflective piece, actually what you've done there is spaced learning. You have consolidated your thoughts and your reflections on the day, but also when you get your results, you can then link back to something that's a bit more contemporaneous, and actually it drives your PDP. You know, I thought that I discussed this really well, but I wondered whether my flow was quite right. Actually then, oh, look at this. All of my assessors said I seemed nervous. So that would have affected my flow. Actually, then I'm going to practice giving short, snappy teaching because that was one that I felt quite bad about. And my flow can improve by doing more spontaneous conversations. So I think that's a great idea. It's not mandated by us. If your deanery mandates it for your ARCP, that again is about what did I learn from it. I think it's a great idea, but it's not mandated.
Thank you. Yeah, that makes sense. I don't know if anyone wants to put their hands up and either ask a question or type it into the chat if you don't want to talk out loud. Otherwise, we might assume that either everyone's fully prepared or they've already done it and agree with everything on your slides.
Or they've been bored into numbness.
But yes.
Okay, let's go with a show of hands, if I may. What would be really good in the chat? And and reactions. So reactions, has this talk been useful? Or if you think that, you know, my opening gambit was, do you feel better about START after the talk than before the start? So either of those could get a thumbs up, and then everybody could write in the chat the one thing that they will take away from START. Okay, I won't read it, but actually in terms of evaluation, that will be really useful for Seb and team for when they have another session. Yeah, so just write in the chat, everybody, the one thing you're going to take away from this. I think there is a hand up, or was it an accident?
Might be in the thumb as well.
Yeah, that might have been a thumbs up, but it was so good. It's every digit up rather than just a thumb up.
No, just I wanted actually to say.
Oh, cool.
So I did the start. I had that talk before the start, and it sounds makes huge sense before and after. I just wanted to say to people who didn't have the start yet, everything that we've just said is true, and it did help a lot, to be honest.
See, I don't lie.
Absolutely.
I don't know. Yeah, cool. There was somebody else. I don't know if that was a hand up or if it was a 5-finger salute.
I think that looks okay, actually.
Cool.
And we've got
so
some good.
There are 52 people online, including me and Seb. So there should be 50 comments in the chat. Okay. I hope you have a really great rest of day. And please don't hold back. If you think my talk was the best talk, just let me know. Yeah. Cool. I hope you have a really great day. I hope you really enjoy your start. I think it's the best assessment going in postgraduate medicine. And I don't say that lightly. All right. Take care, everyone. Stay warm. Stay not blown over by the wind.
Thank you so much. Appreciate it.
Thank you.